Do you want to read it this time?
For something different. I'll try.
Go.
Hello and welcome to the Framework in Focus, a videocast series where we provide insight into our ebook. What's it called, Darren?
It's titled The Musculoskeletal Clinical Translation Framework from Knowing to Doing.
Wow, that's a mouthful.
It is.
So I'd suggest hereunto forthwith we just refer to it as the framework.
All right, I will.
Good. So we hope this series complements the ebook and provides additional insights into the whys, whens, where tos and how forths of the framework. And that aligns with what we're wanting to do, which is facilitate knowledge translation in the management of musculoskeletal pain.
Very good, Tim. I think you've put me out of a job there. Number 9, lifestyle factors. I'm Darren.
And I'm Tim.
And Peter and Helen will be joining us in other episodes.
Yeah, they have already.
That's doing my head in. Okay, so this is our morning slide. We're speaking about the individual elements at the moment, but that's artificial and everything is linked to everything, and this is just a reminder of that.
Yep.
Okay, so all good things are difficult to achieve, but bad things are easy to get.
A smart guy once said that.
Yeah, yes.
So I like this quote, Darren.
Yeah.
And we often talk about this with patients, not in those words, but how our system is quite flexible and adaptable and learns new things.
Yeah.
And coming under lifestyle habits, I think that's particularly important. So we'll talk a little bit of how that relates to people with musculoskeletal pain.
Yeah. And the ebook points to some good resources around this too, doesn't it?
Yep.
All right, so this is from the app. That's a screenshot from the app, Tim.
Yep.
That you can get at the Apple Store or the other one.
Google Play Store for Android.
Yeah. And all proceeds go to furthering the development of the framework, and we don't make anything from that. No. All right, so lifestyle considerations on the app. We have low, medium, high buttons, or on the framework picture, it's a bit of a slider.
Yeah. So really that's to broadly help you think with each patient how much of these lifestyle factors contributing to their overall presentation. So you might have someone with a sore knee, you might have someone with neck and arm pain, and that person might have cervical radiculopathy, for example. So something that might be a specific diagnosis, but it's not uncommon where some of these different lifestyle factors will actually be a major driver, and if we can address some of those, I can think of numerous examples of where that's been, I guess, the highest priority contributing factor, and management around that has really contributed to a resolution of that condition.
Yeah, and understanding lifestyle factors as a risk factors for poorer outcome just in management in general, or particularly, post-surgery.
Yep.
Very important. Next slide then.
Yep, we'll talk about the individual factors now.
So physical activity and exercise.
So we often think of underdoing it, but overdoing it is a common example. And people that think of athletes or deal with athletes regularly, you think about running, and it's pretty well recognised that even up to 90+% of running related injuries are from training errors. So that's often around increasing volume or increasing intensity of training too much. So listening to a person's story around what started or was the cause of their problem, and the main three we'll break that down to was there a specific incident or injury?
Yep.
Was there a clear story of overuse or repetitive or change in volume? Or is it really an insidious onset where there's no clear story? So when someone gives us that story of repetitive volume or an overuse type mechanism of symptom onset, it's really helpful to listen to that.
Yes.
If someone comes in and says, oh, my knee's been flared up because I've gone from nothing to running 5 to 10 Ks 3 times a week, there's a clear story there. So rather than diving into, right, let's look at your biomechanics, there's something wrong here, you might need orthotics, or we're going to change your glute strength to make sure we fix this problem, it might be as simple as, hang on, your tissues at the moment aren't conditioned to tolerate the volume activity that you're asking of it. Let's get things settled down and do a more graduated conditioning program, and that might be all you need to do in that situation.
Yeah, I do reflect on how important it is to get the whole story. I did a half-assed assessment with my mum, as you would.
Yep.
Mum had a sore neck, and she was doing yoga, and she said, she told the yoga instructor that she had this sore neck, and the yoga instructor said, no, that's fine, you can keep doing all this, but it kept being sore, and then she had an x-ray, and there was some degenerative changes there. But she kept going to yoga, kept getting sore, and I finally asked her, well, what are you doing at yoga? And she was doing bloody headstands. Yeah. And it wasn't very good for her neck, doing those headstands. So, yes. So, don't half assess family, just don't assess them at all.
Yeah, that's one good strategy.
Yeah.
So we've talked about overactivity, and obviously underactivity is the other side of that.
Yeah, so sedentary lifestyle.
Yeah. And there's a few parts where we're talking specific causative factors here, for example, people overdoing it. But then in terms of lack of activity, what's your kind of experiences around that with a sedentary lifestyle? How does that contribute to someone's musculoskeletal pain, either directly or indirectly?
Yeah, and actually the first thing that comes to my mind, the link between this and mood, and having those patients that do have a mood disorder or a mood issue around depression, potentially don't want to get out of the house, and the real challenge in trying to get them moving when they're housebound in that manner. Work situations that are very sedentary are difficult as well. Different scenarios like that need different strategies, but certainly, for the sedentary lifestyle or the person that's stuck in one position for a long period of time, just doing kind of those micro break things, getting them up regularly, then a real paced program around, say, walking, something simple. It's the main thing around that is finding something that they're going to stick to and enjoy. It doesn't have to be walking, it doesn't have to be swimming, it doesn't have to be riding a bike, it has to be what they might stick to.
So every person that we see gets exercise, but obviously it's tailored to their presentation. For some it's a reduction in exercise or a modification. You've got to be careful telling people to stop stuff if that's their personality, is that real exercise drive. You've got to offer alternatives, but for other people it's increasing or adding exercise around that. And it kind of ties into the obesity one as well, where people that are overweight, weight does relate to musculoskeletal pain disorders we know at least a couple of ways. One is the mechanical load, which we used to really focus on, but we also now know that that's associated with increased inflammatory markers in the system, particularly around increased abdominal obesity. So you've got a twofold potential mechanisms there for contributing to amplifying a musculoskeletal pain issue. And you mentioned previously about risk for surgery as well. Where now a number of surgeons will say to people that are morbidly obese, you need to lose weight before we operate, because it's a known negative prognostic factor for recovery from surgery as well.
And can be tricky to bring up with the patient. People might feel uncomfortable around that. So I like the strategy that come from Kim Bennell as part of the PACE trial around, just saying, look, we understand that weight is a risk factor for this. Is that something you would like more information about? That's a kind of non-threatening way to go into that.
I often will also ask people, in terms of your weight, since your injury or your onset of your symptoms, has your weight gone up or down, or has it stayed about the same? And then people can be a bit more comfortable to say, I've actually put on more weight. I know I was already carrying weight, but now my weight's even more. And then the same thing, is that something that you think's important or that you need to do something about? Because it's very difficult to tell someone that they need to lose weight, for example.
Very difficult, but can be such a, for knee OA, we know that's one of the biggest predictors of outcomes. So you can give them all the exercises you want, it might not be enough if they're not making these broader changes.
And that comes back to those clinical practice guidelines, and I use that often now, where I'll refer them to other resources around the OA and say, look, we now know the 2 key management strategies for doing well with this is exercise and weight loss.
Yeah.
And if resources are putting that out there, and we know if people lose weight, that is associated with better outcomes. Again, it is our responsibility to give people the right information in the right way, and I find that is often better received when you're talking about the science behind it, if you like.
Yeah. Okay.
Maybe while we're on that, we've obviously got obesity and low BMI, which also applies to diet and nutrition to some degree.
Yeah.
So extreme low BMI or underweight is also associated with increased musculoskeletal pain and poorer outcomes. Many people ask me about diet and nutrition and often supplements.
Oh, yes.
How do you deal with that one, Darren?
Well, I do suggest a dietitian at times around that. In terms of supplements, again, I guess I don't know enough about them, to be honest. Maybe there's something, you know, for glucosamine or something like that, maybe for joint stuff. I know that's quite debatable, but I think there maybe is some evidence that could help pain for some people. But more broadly, I just don't know the research, so I suggest they speak with their doctor or someone that does know about it.
Yeah, well, there's a few things there also. I think there's a whole para or quasi health industry around these supplements that you know feeds a lot of these consumer beliefs, and as you said, there's little bits of science around some of these things, but often the broad I guess summary around this is there's poor evidence for specific supplements or dietary approaches. I will often say to people, there's not convincing evidence, but you'll get individuals reporting positives from this, and if that's something they really want to try, then they can do that, considering the potential risk benefits around each one. But I'll also often recommend, well, hang on, if you try this, set a time frame and really try and examine, is it helping you or not? So it becomes down to them being informed around that. The other bit that is, I guess, more knowledge around is gut health and some associations of that with other pain disorders, and then obviously the immune system impact on that. So there's no doubt there's relevance of it.
Absolutely.
And also it's not my area of expertise. So again, on referring to other health practitioners, as you say, nutritionists or dietitians can be important around that, or people with more knowledge or interest in that area, I think.
Good.
Back up to sleep.
Yeah, let's go to sleep. So the bidirectional nature of the relationship between sleep and pain is well known. I guess very difficult when pain is really driving sleep disturbance.
So you're in pain and you can't sleep because of the pain, but our system reset for physical and mental health is sleep. So we often say to people, you need to get more sleep, and they're going, well, I'd love more sleep. So how do you deal with that?
Well, 2 options, I guess. One is around medication, and you know, I understand that some people don't like taking medication, some people are comfortable with that, but I always suggest that it's worth discussing with the GP a trial of a particular medication, at least for a couple of weeks, just to try and make inroads into your sleep debt for a short period of time. And the other one is a sleep hygiene assessment, which is extremely valuable and extremely rarely done.
Agree on both of those points. I think one of our roles, again, if it's not an area of expertise for the individual health practitioner, you can do really well just by identifying this is high up on the contributing factors list. So just in communication with the individual patient, to be going, look, from what you're telling me here, and you see people where they're getting 2 hours sleep a night, and that's been the case for a year. And there's research around amplification of pain symptoms and other general health effects of poor sleep. So even communicating that and going, right, we understand maybe your pain's a major driver of this, but if we're going to focus our efforts on helping you recover, all the other bits might be in place, but if the sleep bit's not being managed, that might be the barrier.
and that's to link this back to the other elements, to the psychosocial again. So sometimes people might not be sleeping because they're ruminating and thinking about their situation or their pain all the time. Or the other common ones, impact of events, say after whiplash injury, motor vehicle accident, where they're dreaming about the accident, reliving it. So, you know, they're different issues that might need specific psychological support for those.
So a couple of easy questions.
Yes.
So as a clinician, obviously one is, how is your sleep? We use the short form Orebro screening questionnaire, which has a specific sleep question. So if people are marking less than 7 out of 10, I will then tend to bring that up and go, look, you've scored 6 or 4 or 2 on your sleep here. I don't then assume straight away that the pain's stopping their sleep.
No.
Mm-hmm. And so my usual question around that is, I note here you score your sleep poor. Is that because of your pain or other reasons?
Yep.
And that people typically will say, yeah, it's my pain, or people say, no, I'm worried or I'm anxious or I'm not sleeping well.
Yep.
Some people will say, I've never been a good sleeper. So that opens up the conversation around you know, what might be contributing to that sleep. So at least if they acknowledge that's an issue, I think that's a really good starting point. Other things that you...
do they feel rested in the day?
Yeah.
You know, just as an overall judgment of whether they're getting enough sleep or not. I always wonder about sleep and inflammation, you know, and this is a completely throwaway line around, during the day you're moving, your blood's pumping, at night you stop moving, inflammation can build up. I don't actually know if that's true, but it's a good story to bring to people. What do you think about that?
Again, I mean, I think there's some relevance. We know if people have inflammation that it tends to be worse after being still, so they'll certainly be stiff and sore in the morning. So there's the different drivers of what's limiting their sleep. If someone has an inflammatory pain pattern, then medication for inflammation might be helpful. Versus if it's broader just because of pain, then there's different medication to deal with that. But whichever strategy you implement or the person chooses to implement, we always recommend try this for a time period and review, is it being helpful or not? Because the danger is, if it's a long-term problem, people have 15 different things they're trying to do about different parts of their problem, which isn't necessarily helpful. So we need to check in on that. And set timeframes.
Self-medicating with alcohol. Do we have alcohol on here? We do.
Yeah, we do.
Good segue. Self-medicating with alcohol, you know, to get sleep sometimes comes up. Clearly that's not a good way to get sleep.
No.
Not every week anyway. No.
It often works as a short-term strategy, but long-term there's so many other negatives around that. Never advocate that.
No.
But
it can be tricky. Well, I mean, people will bring that up, so definitely I'll say, okay, you need to speak to the GP about this.
Or even at a minimum, acknowledge that helps you at the moment, but long term that's not sorting it out. But you can't take something away and not offer something else. So that's where we need to have a few options in our armoury in our discussions around that. So on alcohol, what's the problem with alcohol?
I don't have a problem with that.
So what do you say to your patient that says, I'm drinking 2 bottles of wine a day?
I will kind of reflect back on them. Do you think that's a good strategy going forward? And most people will be pretty quick to realise that it isn't. So then you open up a discussion around that. So
it's often a coping strategy, and it's I guess an angle in that they need other assistance or other ways of coping with their pain.
Yeah, it is. And smoking's another coping strategy that many people will fall to.
So why is smoking bad? I mean, you've got someone here that says, well, hang on, you're telling me now I need to stop smoking, but I've smoked for 30 years. What's your sales pitch or your rationale there? Yeah,
it's interesting. I think smoking's clearly a risk factor for musculoskeletal pain, all of them.
Why?
Well, it probably relates back to underlying inflammation and sensitivity.
And we know it delays healing. So for surgery, often the surgeons are
the negative effect on healing.
It's
not. What's not so clear, and I want to do a clinical trial on this. Don't tell anyone. Just keep it secret. It's not clear whether stopping people smoking actually helps their pain. Not to my knowledge. So it is a bit tricky, but I do broach it from both. So I'll tell them, it's a well-known risk factor for pain and delayed healing. I'll drop the line that some surgeons won't operate on you while you're smoking, which is not made up. That's true.
Yeah.
If I was a surgeon, I wouldn't be operating on a smoker.
Not if it adds risk. But the positive out of that is most people say they would like to give up, and if there's a clear line in the sand, such as around surgery, or some clarity of your healing's likely to be impaired because of this, that could be one of the things that helps them have that success towards stopping smoking.
Yeah, absolutely, and that's where, as you said, if that's their coping strategy, you can't take that away and not replace it with something else.
Yeah, and again, on referral to other healthcare practitioners around that might be your role. Yeah. It's not your job to tell everyone to stop smoking necessarily. Yeah. You might raise that as a potential issue. Yeah. And if that's something they want to try and deal with, then we can on refer from there.
And look, I have made a conscious effort myself over the last 6 years to actually discuss that in that way with the patient, in terms of the risk factor profile.
And how have you found that?
Yeah, I think I've found it okay. Like a lot of people, I can't change them in 2 minutes of talking to it around like that, but I do feel better within myself that I've broached such a known negative with them. So, and I try and reinforce that then with the other practitioners. And it is not just about their pain; it's about their whole well-being.
Yeah. All right. I think we've covered most of the main ones. So, as you can see from the list there, there's broadly a range of factors that we put under that lifestyle umbrella. If you go back to the previous picture, so we rate there low, medium or high, and I've given the example earlier about someone that's hurt their knee from an increased volume of running. In that instance, I would rate that high, therefore that should be a key focus of your management. Yeah. If you take the smoking one, how much does that weigh into it? That's a bit hard to say. The sleep and the activity levels, they might be key, and like I can think of examples of people with pre-existing mental health issues. Anxiety is a classic example where their normal outlet for managing their anxiety is cardiovascular exercise, which is known to be very effective, and they can't do that because they've got an injury or pain that stops them. So in that instance, if you're thinking their mood impacts on their symptoms, well, are you actually treating the mood, or really if you can get them exercising again, which is their strategy, but you might have to come up with alternatives around exercise options for them. Again, the lifestyle might be rated high, more so than the mood related side of that in that instance.
And I guess relating the lifestyle factor and activity to pain, the pain features, elements of the disorder, and there is that, if you exercise you'll release endorphins and that'll make you feel better, but some people with pain, it would appear that mechanism is broken. Even been looking at some data recently in people without pain, and there's a massive variation of responses, which, in terms of pressure, pain, sensitivity to different forms of exercise, which is no real surprise when you think about it. But again, it's nice to think, how does this stuff relate to other elements within the framework? Well, there's a clearly direct link between physical activity and pain sensitivity, and the same goes for obesity, highly linked to that.
Yeah, and you've mentioned earlier about people being prescribed exercise, but asking them what do they normally do or what would they like to do. I mean, the classic is people are injured and they can't weight bear or tolerate weight bearing so well, so we say you need to get in the pool. But there'll be a number of people that say, I don't like getting in my bathing costume in public, or don't like going to public pools, or I can't swim. So we've got to develop something as a collaborative process around that, and even if they're starting small, that's okay if they're at the time doing nothing.
Yeah, exactly. Get the spa fixed yesterday, Tim?
I did, Darren.
Very good. All right. I think I'm pretty comfortable with that.
Yeah, hopefully that adds a few more useful insights.
Yeah. So this is a little picture from the website. If you go to musculoskeletalframework.net, you will see that ebook and that round circle with some writing in it.
Yeah, and that ebook looks like a real book. There's no printed copies. There is only an ebook.
Yeah.
But the picture looks good, and we're into saving trees, so
Yep.
yeah, electronic version only, I'm afraid.
Except we may do the special edition in print of that cover from the first episode.
Yeah,
You
good
haven't seen
point.
that cover, go back to the first episode, and it's a
Check
good
it out.
cover.
Yeah, we'll let you know if that's coming up.
All right, thank you, and we will see you next time.